Started. Hi, everyone. My name is Kristen Bellamy. I am the marketing rep for Rothman Orthopedics in New Jersey. And we have Dr. Michael Rivlin here with us. He's one of our orthopedic hand and wrist surgeons. So I'll just give you a little bit of background on Dr. Rivlin. He will do a talk, and then at the end, we'll take some questions. I do ask that the questions are kind of more general in nature. We can't really answer patient-specific questions over this forum, but if you have a more specific question, you can reach out to me and I can, send the question to Dr. Rivlin, or, if it makes the most sense, we can get you scheduled to see him. And so just a little bit about Dr. Rivlin. He is a board certified orthopedic hand and wrist surgeon. He specializes in all conditions of the hand, wrist, and elbow, and he is the chief of orthopedic surgery at Jefferson Health, New Jersey. He completed his training in hand surgery at Mass General, part of Harvard University, and he has a special interest in complex fracture care, minimally invasive arthroscopic techniques, carpal tunnel syndrome, nerve, and microsurgery. He's also part of our orthopedic oncology team for upper extremity tumors and complex reconstruction. He is a published fellowship-trained physician who is a dedicated educator and clinician. Dr. Rivlin sees patients in our Marlton, New Jersey office, as well as Center City, Philadelphia, and Bensalem. And I think that's it for me. So please, again, if you have any questions, put them in the chat. We will answer those at the end, and I'll turn over to Dr. Rivlin.
Hi, everyone. Thank you so much for joining me in my basement anytime. So, Kristen, thank you so much for the introduction. So, I wanted to make a generic discussion about nerves that applies to hand surgery, and we might hit a couple of nerves here. At the end, I want to open it up to questions. There are no stupid questions. Please feel free to ask. And what we want to talk about is upper extremity issues that relates to nerves. So many people throughout their lifetime get numbness, pins, needles, or hand pain. And you probably know somebody that has nerve compression. And we will talk about some of those. So, what are nerve compression, or what we call compressive neuropathies? Those are, and some of the abbreviations that we will talk about, carpal tunnel syndrome, or CTS, cubital tunnel syndrome, or CUTS. What we don't talk about is stuff that compresses nerves higher up, such as neck compression, which is cervical problems, cervical radiculopathy, cervical myelopathy, trauma, and temporary nerve injuries or arm ache. So those we will not cover. We will focus on the most common ones. I want to address this because I think the audience has different levels of people that are interested about nerve and nerve issues. So I want to give a little bit more flavor to people that may be patients, people that have relatives who are patients, and there are some professionals on this call as well. So we're going to tailor this to everybody, and we'll go over what is pertinent to all. So how common is this? First of all, compressive neuropathies, such as carpal tunnel, is very common. About 5 to 10% of us will have one of these. And as the population ages, as we live longer, and as much as we try to go to the gym more with obesity, with aging population, it is going to increase. This is a modern day epidemic that we want to keep in mind because it will continue to get worse. So we will first talk about carpal tunnel syndrome. And a lot of people think that carpal tunnel syndrome is really any problem with the hand. And hey, yeah, I banged my hand yesterday and now I have some pain. I probably have carpal tunnel syndrome. So what we'll learn through this is knowing what actually carpal tunnel syndrome is and how do we differentiate it from other issues. So carpal tunnel syndrome, and I don't know if you guys can see my marker or my pointer, is carpal means wrist. Tunnel is where more structures go through. So this is a fairly poor design. The way we designed, and this is a cross section of the wrist, we have a tunnel where the bottom is bony. And the top part, which is close to the palm, is a very, very strong ligament that comes across. And the reason I say it's not a great design is we have a nerve that is fairly sensitive that goes under this bridge and multiple tendons that move back and forth, that move our finger, go in the same tunnel. It is rare in the human body to have a moving part next to a nerve directly with a ligament on top. So this construct creates carpal tunnel, especially when the tendon gets tighter. I'm sorry, when the ligament gets tighter. So most of the time, how do we get carpal tunnel? Well, most of the time we don't know. It's most likely genetic. So if your mom had carpal tunnel and your father had carpal tunnel, you probably will have carpal tunnel as well. We call it idiopathic, so we don't have a specific link to it, but majority of genetic. Medical problems. We know that C-spine or cervical spine problems, rheumatoid arthritis, thyroid problems, and it can be hyperthyroid or hypothyroid, as well as diabetes, predisposes us to get carpal tunnel. That doesn't mean that if you have diabetes, you will definitely have carpal tunnel syndrome, but you're more likely because we're talking about a tunnel where multiple structures go through, fluid imbalance, such as what patients have during pregnancy or dialysis patients, fluid imbalances can cause carpal tunnel syndrome, such as pregnancy-related carpal tunnel, which is numbness in the fingers, as we'll see in a minute. Trauma. Any injury across the wrist can cause carpal tunnel syndrome if it's bad enough. Any bruising in the palm can theoretically lead to carpal tunnel. Wrist fractures such as dislocated fracture are common. Uh, Population that puts their wrist in extremes of motion, think of people that chop wood or process meats, can create carpal tunnel syndrome. Now, one of the biggest myths that if all of us remember is that, hey, I type, I get carpal tunnel. That over of the last 30 years have been disproven significantly. As a matter of fact, you typing does not cause carpal tunnel. However, if you do have a predisposition to carpal tunnel or you have carpal tunnel already, you're going to hate to type. However, typing alone generally is safe and does not cause carpal tunnel syndrome. There are many studies that have proven that those studies are most of them are from 1980s when the computer generation started to have carpal tunnels. So how do we know that we have carpal tunnel? And while you guys are watching this webinar, I encourage that all of you can do the Phelan test, which is putting the two backs of the hands together. And if you hold it for about 30 to 60 seconds, if your fingers go numb, likely you have carpal tunnel. Hopefully none of you guys have carpal tunnel and you're just signing in just to learn about this. So that is one of the most sensitive tests. There are other tests that are performed by your primary care physician or physician that can eliminate some other causes of numbness, such as neck tests and thumb tests, as you can see. So how do we figure out if indeed somebody has carpal tunnel besides the examination of putting your hand in that specific position? The first thing that we encourage everybody to do is to try splinting. Splinting at night is very helpful for diagnosing carpal tunnel syndrome. Carpal tunnel, as we'll go into, is mostly a nighttime condition. When we wake up with numb fingers, and again, those are fingertip numbness, they generally are numb when carpal tunnel syndrome is mostly at night. So using a carpal tunnel brace at night not only can help the symptoms, but also diagnose it. If the numbness completely goes away with nighttime splinting, we know it's carpal tunnel syndrome. EMG or some people call it the needle test or electroconductive studies. Those also are the gold standard for diagnosis carpal tunnel syndrome, where we test the nerve conduction. That is the most sensitive way, most appropriate way to tell not only if we have carpal tunnel syndrome, but how bad it is. It is always important to do a full neck evaluation because what's called a double crush syndrome, the same nerve in the neck and in the wrist can be compressed, and that is called double crush syndrome that can be significant. A hand surgeon sometimes will do an injection if it's difficult to determine whether the carpal tunnel nerve compression comes from the wrist or some other area. In general, injection is truly reserved for diagnostic purposes nowadays. It used to be considered a treatment of carpal tunnel that because of the risk associated with injection near the nerve, that has significantly fallen out of favor over the years. So, who do we get a nerve test? Well, most people that have carpal tunnel syndrome, especially before considering treatments such as surgery, even with classic symptoms, we often get the nerve test EMG. That is the definitive treatment. The nerve test will tell us three options. One is if it's mild, so mild nerve compression can be treated without surgery. If we catch carpal tunnel early, splinting, activity modification, and even some vitamins and therapy can occasionally help with progression of the disease. What we as surgeons want to catch people as, and I say, green is the mild ones, generally that does not need us as hand surgeons. Moderate carpal tunnel or nerve tests, we want to make sure we find because any moderate carpal tunnel will go into severe. Moderate is where we say go no further. Moderate carpal tunnel requires very, very close observation or surgery to prevent it to go to severe. When we have somebody with severe carpal tunnel, and this is where I spend most of my time talking to patients, is once we have severe carpal tunnel, that means we already have nerve damage. Even though surgery can help, if the nerve is no longer functional, the outcomes of surgery are much worse than if we get to it early. And that's why some patients every day say, hey, I have a neighbor that had carpal tunnel surgery and it didn't work for them. The carpal tunnel surgery is 98% effective if done in moderate category. If we already have nerve damage, the surgery still works, but it does not give the same benefit. So it's not that the surgery doesn't work, it is something that unfortunately no longer can be helped. So carpal tunnel syndrome is very age related, and there are things that we have to look for. One is it is very rare to have carpal tunnel when you're young. Short of pregnancy, it is unusual to have numbness in the finger. Remember, carpal tunnel syndrome is a hallmark of numbness in the fingers, especially the three fingers, the thumb, index, and middle finger. If you have no numbness, it's probably not carpal tunnel. If those fingers are numb and you're under 20, absolutely needs evaluation because it's very rare to have carpal tunnel. I'm in the not so young category, and those patients that have carpal tunnel symptoms in the 30s to 50s are more likely to be managed without surgery, can get patients through it, hopefully avoiding surgery. Anybody over 65 has limited nerve healing potential. It is important. Anybody over 65 with numbness in the finger to be proactive about, because once the nerve stops working or not working well, weakness, dropping things, don't feel the keys in the pocket, that's when we want to make sure we don't delay, because once nerves over 65 don't heal, they're not going to return. Over 80 years old, carpal tunnel does happen as well. Unfortunately, numbness generally doesn't go away for most patients. Even if treated with surgery over 80, it is done for pain control. So how do we treat them? And who should not get any treatment besides surgery? Who do we say, okay, we must do surgery without any other treatment? Anybody that's already has atrophy. What is atrophy? Atrophy is loss of strength, loss of muscle. Once the nerve no longer can move the hand or no longer has strength, we generally recommend intervention because anything else will delay the outcomes. Anybody that has persistent numbness over 1 year. So if you have carpal tunnel syndrome for over a year, please don't ignore it. Naturally, any severe findings on EMG, which we call denervation, when the nerve no longer functions well. If we do carpal tunnel treatment by splinting, and the splint used to create complete relief or used to make patients not wake up at night, but all of a sudden that no longer helps. Carpal tunnel surgery should be considered because, again, that's usually the sign that the nerve compression is getting significant. And then injections. If somebody gets an injection and that helps, that's important that we treat. This is what I mentioned by loss of strength, loss of muscle. If you take a look, there is atrophy right at the thumb muscle. If that muscle is going away, that is start of losing function in the hand. We do absolutely want to prevent that. We are very proactive at intervention before that happens. What do we think we call differential diagnosis? What else can cause carpal tunnel symptoms? Think neck. Neck is the number one area where carpal tunnel-like symptoms can happen. Again, if you have pain shooting down the arm from the neck, that is very much possible that it's at the neck, even though the fingers are numb. We are not going to discuss too much thoracic outlet syndrome, which is the nerve compressed in the shoulder, or trauma, because we talked about those are things that we need to do tests for, but there are certain other conditions that can mimic carpal tunnel. So how do we treat carpal tunnel? What's the cure? So there are traditional ways of treating carpal tunnel syndrome. We call them open carpal tunnel releases. There are two major options. One is called a small keyhole incision or a mini open incision, and there's the traditional carpal tunnel surgery. I would ask the audience, hey, which one would you like to do if it was your hand? Well, if it was my hand, please do the one on the left with the tiny incision. The effect and the benefit is the same. The one you see on the right side is really no longer performed routinely. The smaller incision, the quicker the recovery. If you can see on the left, it's a very small incision. However, rather than open carpal tunnel, we have over a decade endoscopic, which means camera-assisted carpal tunnel surgery. If you look at the left side, we can use a little tiny incision that's about a third of an inch or a quarter of an inch incision, just enough to put a camera about the size of a pen into the palm, and we can accomplish the same exact release as done with open procedure. You can see on the right side that using a camera device can do the same effect. And some patients refer to this as an inside-out method. What is the benefit? Well, carpal tunnel syndrome treatment using endoscopic technique makes people return to doing whatever they want. It is a much quicker return to work, much smaller incisions, so less issues with wounds and all that. It returns patients to improve grip strength faster, even 3 months faster than the open surgery, and decrease scar pain or palmar pain, we call pillar pain. What's the disadvantage? Um, there are no significant disadvantages. The only disadvantage is it is a newer technique. It's been around for about 10 years. Not every hand surgeon is trained to do that. And it's something that, again, you do not want to have that surgery by somebody that has only done 10 of them. It does take some practice to do. Naturally, like any newer technique, I used to say this is a new technique, but again, it's been around for 10, 11 years. And again, something that I do 99% of my patients. I do endoscopic carpal tunnel release over a decade now. It does allow us to return to work and return to doing faster. Now, a little bit about what happens in surgery. And the surgery does the same thing whether we do it open or with an endoscopic technique. If you can see on the left side, there's that ligament that we saw before. That ligament has a nerve that is labeled median nerve, and you can actually, it's a little cut off, but you can see it's the median nerve. That's the nerve compression that causes carpal tunnel syndrome. If you notice, we open that ligament so that nerve is no longer compressed. If you look at that little caption, and I don't know how well it projects on the top right, that transverse or across the screen white is that ligament. When we cut it, you can see that the nerve is next to it. We don't touch the nerve, but we open up the tunnel so it's no longer compressed. So recovery, what happens to the patient after this 5-minute procedure? Well, as you have seen, the incision is tiny. We don't put any stitches on the outside. There's no dressings that we put on. I jokingly tell patients you don't even get a Band-Aid. We use a little skin glue on top. And I let patients do whatever they want right after, as soon as they not lift anything more than a coffee cup for about a week. It is very rare that splints are needed. So even though braces are the number one way of managing carpal tunnel before surgery, the good news is most patients can throw them in the trash the night of surgery. Therapy is very, very rarely required, and patients get stronger for the first 12 weeks, and the nerve continues to heal for about 2 years. That means even though some numbness can persist, the longer you had compression, the longer the numbness may persist. Usually it heals very quickly, but improvement of nerve function can happen over 2 years. So the nerve takes time to improve. So we talked about carpal tunnel syndrome. I'm going to stop there for a second and ask if anybody has any questions on carpal tunnel syndrome, surgery, or anything of sorts. I think we have a couple of Q&As.
Okay, so there's just one question in there, and it says, I'm in my 70s and get acute pain for a few seconds periodically when I open jars. Thoughts?
Okay. So one thing that we learned from carpal tunnel, and that's a great question. Carpal tunnel is a numbness problem. Okay. If we are not having numb fingers, you probably do not have carpal tunnel. That's not the main thing. Carpal tunnel is really pain in the fingers, numbness in the fingers, mostly at rest. Think of it as a pinched nerve that is just really unhappy. You don't need to do anything to make the hand hurt. So most of the time, patients have night symptoms, nighttime having to shake out the fingers because they're so numb. That is the common carpal tunnel symptoms. If we don't have numbness, generally don't have carpal tunnel syndrome. Opening jars and stuff like that can trigger some carpal tunnel symptoms, but that's more likely that that's mechanical, such as arthritis or other things. So to the question that was raised, that does not sound to me like carpal tunnel, more likely to be something like arthritis, especially when you're gripping. Any other
Okay, that's the
questions?
only question in there right now. Oh wait, sorry. Oh, now they're popping up.
Sure.
Um, I need both hands done. How long should you wait in between? I'm right-handed. Well, I would rather do the left hand first.
That is a great question. So I will tell you a little quick anecdote. When I started hand surgery about 12 plus years ago now, when I started, I did not do endoscopic carpal tunnel. I did open carpal tunnel surgery. And I generally recommended people to wait around 3 months between the two. One of the biggest surprises when I switched to endoscopic carpal tunnel is how quickly patients got better. To the point is that when I see patients back on their first visit, which is usually a week out, about 80 to 90% of patients that have both sides schedule surgery for the other side within a week, which has never been the common scenario before doing endoscopic. We generally schedule left and right 2 weeks apart because in 2 weeks, most patients go back to doing everything. Now, I do carpal tunnel surgery on both sides at the same time. I tell patients that takes a select person to do both sides at the same time. Just to talk about anesthesia for a second, I do about 70% with patients asleep, which is similar to a colonoscopy sleep. But about 30% of patients I do under just local anesthesia, which means I inject a little lidocaine and I talk the patient through the surgery. Takes about 5 to 10 minutes and does not require you going to sleep. It depends on patient factors, health of the patient, severity of the carpal tunnel, and if I'm a tough cookie as a patient or not, to take one hand or two at the same time, but those are all options. So doing endoscopically, to answer your question, I do recommend waiting 2 weeks unless you want to do both at the same time, which is also doable.
One more question. How do you distinguish carpal tunnel syndrome from peripheral neuropathy?
That is a very good question. So sometimes that can be confusing. Peripheral neuropathy generally involves all fingers, numbness in all fingers. Carpal tunnel generally affects the thumb, index, middle, and the ring finger or part of the ring finger. It usually does not affect the pinky. That is not always the case. Nerve test, EMG, is the best way to differentiate peripheral neuropathy, but some have peripheral neuropathy with carpal tunnel. And I encourage patients that have both. Again, peripheral neuropathy is just a disease of the nerve itself, all nerves themselves. Patients that have diseased nerves have to be more aggressive about carpal tunnel treatment because diseased nerves don't heal well. So they don't take a joke. As I say, carpal tunnel with peripheral neuropathy, we should be more aggressive at treating because if that nerve stops working, it's never coming back. That's a great question.
And then there's another question. It's not directly related to carpal tunnel. Do you want to
Sure.
hold on that?
Why don't we go for it? Let's see.
Okay. I had reverse shoulder surgery in January of 2025, and a week later, my right hand was in pain. After that, my fingers have pins and needles, and it wakes me up at night. I have no strength. I had no strength, and that's coming back, but I still have the pins and needles.
Sure. So the shoulder surgery is high near the neck. There are nerves running next to the shoulder. It is very difficult to differentiate exactly what is happening again just by the question. But there's many scenarios. There is potential of unhappy nerves in the shoulder after a shoulder surgery. However, one of the reasons people can get carpal tunnel is fluid imbalance. We talked about pregnancy, we talked about other stuff that makes fluid imbalance. The swelling that happens after shoulder surgery can be significant. Swelling generally winds up in your wrist as gravity pulls the swelling all the way down, especially in your sling. It is very common for people that have shoulder surgery to wind up with swollen hands and developing carpal tunnel after surgery. It's not because the surgery did something to the carpal tunnel, it's because surgery created fluid and fluid has nowhere to go. It winds up in the palm and carpal tunnel, and that can create carpal tunnel syndrome. But that
Oh,
is
that's
a
super
tricky way
interesting.
to differentiate. Yep.
Yeah. Is there anything you can do to avoid carpal tunnel besides having better genes?
Great question. We know that diabetes is one of the most important cofactors. So, how do we avoid diabetes? Yes, most of it is genetic. Healthy eating, healthy habits are great. Now, certain things predispose to carpal tunnel, and I didn't want to go into too much of a tangent on that, but it's a great question. Things or jobs that predispose to carpal tunnel. Again, it's not typing, although please have good hand posture and good posture when you type for a long time. What's more important is repetitive work that has impact with it that is vibrational. So think of using a jackhammer, think of chopping wood, think of meat processing. That repetitive work and working in cold environments, those are the things that can create carpal tunnel, even if you don't have genetic predisposition to it. So proper ergonomics is key, and repetitive motion and vibratory tools should be eliminated if somebody has carpal tunnel or onset of carpal tunnel.
Okay, that's it for now.
So we're gonna go into the second most reason that people have numbness. So we talked about carpal tunnel, okay? Cubital tunnel is an elbow tunnel. Now, The elbow tunnel, so carpal means wrist in Latin, cubital means elbow in Latin. So this is the elbow tunnel, a cubital tunnel syndrome. It is a different nerve. Most, and for some reason the picture doesn't come up, it shows numbness in the pinky and ring finger. Remember, carpal tunnel is numbness in the thumb, index, and middle. If you look at this, the camera for a second, it's these three fingers. Cubital tunnel is the pinky and ring finger. Okay. Pinky and ring finger numbness is usually related to elbow tunnel compression or cubital tunnel compression. And what happens, it's a different nerve. Remember, median nerve was for carpal tunnel. Cubital tunnel is the ulnar nerve. That's actually the funny bone. I challenge everybody to feel your funny bone. And if you massage it and you have a little pinky shooting discomfort or numbness, if you press on it or massage it, you may have mild cubital tunnel syndrome. That is a nerve that goes through multiple tunnels in the elbow. That is also common. Think of it as numbness and tingling when you bend the elbow. So thinking about, uh, I use the phone and I hold my phone to my ear. If I hold it long enough, my fingers go numb. Or somebody says, I read in bed. And when I read in bed, I have my elbows flexed. And when I bend my elbows long enough, my fingers go numb and I have to shake out the hands. That is a hallmark of cubital tunnel syndrome. EMG is again very important in diagnosis. We can splint it, and you can see a splint on the right side, which is essentially a soft tube that we can put our arm through it. That helps not bend the elbow at night. Again, this is very often at night. Some that don't have splints, we encourage rolling a towel or wrapping a towel, a thick towel around the elbow at night so we prevent from bending. But importantly, again, um, Kristen knows that this is my picture. Sorry to use mine. Just kidding, I wish. There can be compression across other sides. So we covered the wrist tunnel, which is carpal tunnel syndrome. We covered the elbow tunnel, which is cubital tunnel syndrome. But there are other tunnels where nerves can get compressed. The take-home message is talk to your regular doctor. If you do have numbness in the fingers, uh, we are very happy to see you as hand surgeons. We can figure out where that's coming from because there can be other tunnels that get compressed. In general, we can successfully treat most of these as far as we can as soon as we get to it in time. Thank you so much. We went just a little bit over half an hour, but I want to open it up for any other questions. And again, Kristen, if anybody has anything specific, you feel free to email me.
Okay. No, I just have somebody asking about location, so we'll wait and see if any other questions pop up. We got an excellent, which is appreciated. Mhm.
While we wait for more questions and people start dropping off, I wanted to thank you, Kristen, for putting this together. Really appreciate it. I'm very passionate about helping patients with numbness and tingling because, again, that's something we can help with. Whether you're an athlete, whether you're a stay-home mom, or you're retired and a bingo champion, we got you. So if there's anything we can do, please feel free to reach out.
Okay, I got a question. I'm not sure if it's a typo. It says, could schwannoma scar tissue, is that the right word? I've never heard that word before.
That is the right word, yeah.
Okay, could that cause scar tissue, or could schwa that word, scar tissue cause pain on the pinky side of the hand?
Okay, so that's a very specific in that question. So schwannoma is a nerve tumor that is very, very sensitive. Schwannoma is essentially looks like a cocktail onion that can grow inside the nerve, and it can be so sensitive that even a fan can blow on it and can have burning sensation in the fingers or anywhere else. Somebody touching it can cause excruciating pain. I will tell you that I just had a young female who's in her 20s that had a schwannoma. I do peripheral nerve surgery, so it was in her thigh. She could not walk up the stairs. That's how much shooting pain she had from a tiny uh, little bead size nerve tumor. Once we took it out, all her symptoms went away the hour after surgery. So schwannomas can be really painful and very annoying. Some schwannomas can scar, and there's others that live inside nerves that are difficult to manage. And yes, nerve scar and schwannomas surgically removed can cause numbness, even can cause deficiency. That's a tough subject, and I can talk about an hour about it, but yes, it can. And some might have some treatment options, but these are difficult problems.
Are there any other diagnostic tests that can be done if EMG and NCV are negative?
So somebody that asked the questions knows this well. So yes, ultrasound can be helpful. Ultrasound does not give us the full picture, but ultrasound is helpful. There is a questionnaire which is this called the CTS-6 that can also be. However, I will tell you the nerve test done by a trained neurophysiologist is a very, very sensitive test. There's about 5, maybe even 10% of the population that has EMG negative carpal tunnel syndrome, and there are ways to treat that as well. So the short answer is EMG is very sensitive. If that's negative, it is possible that it's not carpal tunnel syndrome, but there are other things like ultrasound and CTS-6 that can help us diagnose it.
Great. Thoughts on B6 deficiency and fingers tingling?
So B6 deficiency can cause tingling, can cause even neuropathy. So short answer is B6 supplementation can help in patients that are deficient. However, it used to be thought that B6 will help with carpal tunnel syndrome. So it turns out that B6 supplementation only helps if you're deficient. If you have normal B6 levels, it probably doesn't make any difference. It's like, hey, I drive without a seat belt, but I take vitamins, so I'm gonna be okay. It probably doesn't work well.
Okay. Next question. Could cervical disc compression cause carpal tunnel, and would an injection in the neck, like a steroid, help diagnose?
Great question. So double crush syndrome, which means compression in the wrist and in the neck, can be additive. So if you have 1 + 1 when it comes to nerve compression, it's like 20. It's not 2. So you can have both problems. That's called double crush. And generally we treat the carpal tunnel first because neck surgery is a lot more difficult and risky. At the same time, neck compression can mimic carpal tunnel syndrome, and occasionally it's difficult to tease out. A nerve test can be helpful, and an injection, whether in the neck or in the carpal tunnel, can differentiate things. I tell patients, hey, I can't tell if it's your neck or your wrist because you have problems both. If I inject the wrist at the carpal tunnel and all their symptoms go away, that is the best test to predict that carpal tunnel syndrome is the issue. Patients that have 100% relief with carpal tunnel injections will have 100% relief with carpal tunnel surgery, except that the injection is usually 3 months relief. Carpal tunnel surgery is permanent. One thing about that, people ask, hey, can carpal tunnel syndrome come back? And the short answer is it's rare. 1% chance that carpal tunnel will come back in 10 to 20 years.
What can be done if you're 91 and the pain from CNS at night is nearly at a level 10?
So it's difficult. I have treated high 90-year-olds with injections, even with surgery. I had done surgery in a 95-year-old. He was unfortunately blind and deaf, but he couldn't sleep for 7 years before that. We wound up giving him shots for many years, after which we did a carpal tunnel surgery in 3 minutes with him awake with just local anesthesia. And he was so happy with the results that at 102, when he unfortunately passed away, I was approached by his family thanking us for giving him last 7 years of his life without having pain at night. So it can be treated. Age is just a number, but we get very, very selective when we get to high numbers. So the answer is age is just a number, understanding that nerves may not heal as well, but pain can be still treated.
Oh, that's a great story. Can a damaged ulnar nerve, which has been previously operated upon a few years ago, be further improved?
So I'm going to answer this with the statistics. It doesn't matter what the surgery was the first time from an ulnar nerve release. Doesn't matter how what type of surgery was done, because there's a couple of types. The relief by a second surgery is usually only 50% effective. So flip of a coin whether a second surgery will help.
And on D. Quervain's surgery.
Can you say the first part of the question, please?
It said, can you comment on D. Quervain's
Curving.
surgery?
Sure. Decorative surgery, for those that have not heard about it, is a type of tendonitis. It's a tendon that goes in a tunnel. It is very successfully treated with an injection. It's, by the way, very common in young mothers that nurse. It's an injection that is 80% chance of a cure. So somebody that has Decorative tendonitis, which is a wrist tendonitis, goes on the thumb side. One injection is 80% completely gone. Surgery is a small procedure. It takes about 5 to 10 minutes. Surgery is very, very successful eliminating it. About 99% chance that one surgery for decorates will completely eliminate it forever. So it's a quick, small procedure that works really well, but I do recommend a shot because it's 80% effective. If one shot doesn't work, a second shot can be tried, and if two shots don't work, we consider surgery.
Can a tendon release for tendonitis cause numbness?
So short answer, it should not. Tendons, if only a tendon is operated on or tendon sheet, generally should not cause numbness unless there's nerve involvement for whatever reason. There can be nerves running next to tendons, and things can scar next to tendons if there's nerves around tendons which scar, and there's a couple areas in the hand and wrist that can happen. That numbness can occasionally be part of it, but that's very unusual to have tendon surgery and have permanent numbness. I'm not talking about a couple of weeks after surgery and everything's swollen.
Here's just a glowing review. Dr. Rivlin saved the quality of my life. He did CTS and cut surgery on me after I was in intense pain for a year from a wrist fracture. I was seeing another ortho doctor who told me nothing could be done. My surgery was life-changing, and I'm forever grateful to Dr. Rivlin. That is Susan X
Oh,
Teen.
I figured that must be my mom, but thanks.
Who's your
Thank
wife
you.
over there?
Yes, probably it's one of them. But no, thank you for that. We try to help everybody.
Um, can B12 help with the pins and needles?
So great question. So same thing as B6 and B12 can be tried. Long term, it probably doesn't make a difference, but it is not much downside to trying it. I wouldn't spend too much time. Studies show it doesn't make a difference in the overall outcomes.
Okay, and the last question I see here, are there any holistic treatments to help with the pain?
So pain control is important. Holistic approaches can be from meditation to yoga to using CBD oil, which a lot of my patients now swear by. So those can be tried. Pain is depends. Nerve pain is very difficult to control. If it's nerve pain, I generally have most patients struggle with nerve pain. Again, meditation, yoga, certain massages, and CBD can fall under the holistic approach, besides Tylenol, ibuprofen, over-the-counter stuff.
I think that was it. So thank you so much. Thank you, everybody, for joining. Thank you, Dr. Rivlin. If you have any further questions or you're interested in scheduling an appointment, you can reach out to me. Everybody should have my email and my cell phone number. So reach out to me and I can get you scheduled. But otherwise, thank you all for taking time on this hot, hot day.
Thank you so much, guys. Appreciate you joining. Bye bye.
All right. Good night.